Good evening, everyone. This is Andreas Gomal. I'm a surgeon at the Hospital for Special Surgery in New York, and I have been asked to talk today about advancing the management of knee osteoarthritis, a focus on clinical trial developments. The program information is as follows. This program is approved for 1 CME or CNE credit. The credits will be provided by the North American Center for Continuing Medical Education, an HMP company, and this is supported by an educational grant from Organogenesis. The learning objectives are to review the science of placental-derived tissue as a source of anti-inflammatory and immune modulating factors, to investigate the latest clinical trial data comparing amniotic suspension allograft to saline and hyaluronic acid in knee osteoarthritis, and to examine evidence-based medicine and the hierarchy of evidence. So let's dive right in. I'm sure you've all heard a lot about placental-derived products and the whole push to regenerative medicine is quite popular both in the press, the lay press, as well increasing research and clinical studies. It's a very confusing field. We have a lot of different possible products for injection, and besides the somewhat longer established injections such as PRP or BMAC, there are now multiple placental-derived products. I think what's important to state from the beginning is that I cannot speak to all placental-derived products, but only to one specific one. That's the only one that I have investigated, and I've been part of a randomized controlled trial utilizing this product, and I've also been a consultant to the company, which is important to note. In terms of how different are these products, you can think back when the early outcomes of PRP were quite confusing. It didn't really show anything consistent. And then over the years, we realized that PRP is not equal to PRP. And now there's a pretty good understanding that for PRP, for joint applications, intra-articular injection, for example, for inflammatory arthritis and osteoarthritis, we would use leukocyte-reduced PRP, while if we go more for soft tissue applications, tendinopathy, for example, we would go to leukocyte-rich PRP. And these placental products are a little bit similar because we tend to lump them together. Oh, this is an amniotic injection, but they're quite different. They're different in terms of what actually goes into the product, so the contents, and then how the contents, the original tissue, are processed and preserved. And that determines really what ends up in the final product. Going back to what are the contents of the product, well, there are differences in terms of the structures that are being used. They're all birth tissues, but it could be the amnion or chorion, could be the epithelial or spongy layer, could be the amniotic fluid and any cells that are contained within the amniotic fluid, could be the umbilical cord, and you've heard about Morton's jelly as well that contains a lot of cells, and then any combination of the above. Then what happens to those products once they're harvested? They need to be aseptically processed. Some are terminal sterilized, which of course kills any cells and has the chance to alter proteins. Some are stored fresh, cold, some are lyophilized, some are dehydrated or cryopreserved. And given that this starts as a biologic product with all the variability that we see in the human body, the processing certainly has the potential to either minimize or maximize biologic variability. So it can really make a big difference in the final product, and all of the above factors affect cell viability, if there are any cells in the product at all, the integrity of the extracellular matrix, and then any growth factors or cytokines contained within the product. So I will speak specifically about this one product that we have investigated called ReNu, and this contains cells from the amniotic fluid, but more importantly, it contains amniotic membrane, which has been cryopreserved and is particulated. So what is this? I mentioned this is cryopreserved, and it's termed amniotic suspension allograft because it's really not a structural allograft, but as mentioned, it's a particulated membrane part, a powder essentially, that is mixed with amniotic fluid cells from the same donor. Initially, we all had thought that these stem cell products contain live stem cells, and that's how they function, that we need live stem cells that then would transform into whatever tissue we're trying to regenerate. With increased understanding, and Arnie Kaplan has helped us a lot, we began to realize that it's not really the cells that turn into other cells that then make tissue, but that if anything, the cells secrete factors. So rather than transforming into cells, they're just little factories, medicinal factories, hence the suggested name change from mesenchymal stem cell to medicinal signaling cells, which quite elegantly keeps the same acronym. But increasingly, we've realized that in many of these injections, including ReNu, there are very few cells, and that it's not really the cells that lead to the effects that we see, but that it's more the anti-inflammatory factors contained within. And amniotic membrane is very rich in anti-inflammatory cytokines and regenerative growth factors, such as protease inhibitors, so very important to antagonize any catabolic events in the joint. And these are the tissue inhibitors of metalloprotein, TIMP1, 2, and 3. There's modulation of inflammation, and a lot has been published about IRAP, which is an interleukin-1 receptor antagonist that decreases inflammation, but there's also IL-6. There are anabolic factors such as TGF, IGF, BMPs, and HGF. The first step in looking into any of these products should really be a good preclinical model, both to show that it's safe, but also to try and come up with a mechanism of action. And this was tested out in a rat model with injection of monosodium iodoacetate into a joint. What this does is it creates significant inflammation and degeneration. So it essentially induces disease and pain. At day 7, the animals were then injected with either saline, the amniotic suspension allograft, or as a very strong positive control steroid, triamcinolone. And then at day 21, the rats were evaluated. Their body weight was measured. They had incapacitance testing, which essentially looks at the differences in weight bearing between each hind limb, and only one was treated. The other one was left as a control. They do a von Ray analysis, which is essentially similar to pressure sensitivity, what we do in clinical practice if there's joint line sensitivity with different monofilaments. There's a gait analysis, and then a knee caliper testing just to look at joint swelling. And then finally at day 21, the rats are sacrificed, serum is collected for circulating factors, synovial fluid is collected, and the joints are collected for histology. If you look at the different charts, on the left are the weight-bearing differences, and you can see how two different levels of ASA reduce this. Again, triamcinolone is probably the strongest comparator that we have, and overall, I do use steroid in my practice quite a lot. It's great, it just doesn't last very long. So you can see here that the ASA is between saline and the triamcinolone. For the weight bearing, the same as for the caliper measurements, so the joint swelling, as well as the joint sensitivity with the von Frey threshold. So in summary, injecting ASA resulted in improvements in pain, weight bearing, and swelling of the injected knee in comparison to the negative control of saline. If you look at the synovial fluid and serum cytokine measurements, there are trends for improvement. So certainly IL-6 decreased with the ASA as well as the steroid injection. IL-10 is an anti-inflammatory cytokine, so it's a positive cytokine, one we like to see. That was much increased with ASA injection, interesting enough, more so with the lower dose than the higher dose. And importantly, there were no negative systemic effects that we're seeing. So subsequent to the preclinical model came a small first-in-man pilot study that was done back in 2015. This was designed mainly for safety, not for efficacy. As you can see, I was one of the co-investigators together with my friend and long-term research partner, Jack Farr, as well as Tony Alaprantis, who's a rheumatologist from the Brigham, who did all the serum analyses. This was a small study, just in 6 patients. Again, this was powered not for clinical significance. This was really focused on the safety. These were older patients with quite significant knee arthritis with a KL score of 3. You can see a lot of information on this slide. We did look at their PROs and they trended towards the better, but this is not something I would hang my hat on. These are only 6 patients, but at least it was somewhat positive to see that these patients did respond clinically and actually felt better. The mainstay again was for the safety testing. So we did blood tests on all of them. We looked for general measurements such as blood cell count. We looked at lymphocyte counts, inflammatory markers, but more importantly, we looked at serum IgG and IgE levels, and there were no clinically concerning changes in those, which really made us more comfortable to go ahead to design a much larger clinical trial to now also study the clinical efficacy since the safety was shown in the previous small pilot trial. So this led to a larger randomized controlled trial, which recently was published in the Journal of Knee Surgery. The design was that of a true randomized controlled trial with 3 groups. There were 200 patients that were enrolled in 12 different sites, and they were randomized 1-1-1 to either an injection of saline, HA, and ASA, with primary outcome measures being the VAS pain scale at 3 months and 6 months, as well as the KOOS pain and function subscales, also at 3 and 6 months. Of course, we looked at other PROs as well. So we collected the KOOS pain and function subscales, as well as the VAS technical activity, SANE, and EQ5D along the study course, 1 week, 6 weeks, 3 months, and this was extended out to 12 months, and those results are pending publication. So I don't want to speak too much about those. We also did radiographic measurements at the beginning and at the conclusion at 12 months. This was not to show any change in natural history or disease modification, which would be wonderful, and I think that's the holy grail we're all looking for. But for that, prior attempts have shown we would require hundreds and hundreds of patients, given that osteoarthritis is a very slow disease, so you would only expect very small differences in a comparatively short time frame of 12 months. And there's enough variability just in positioning of the knee getting x-rays that there's a lot of noise. So it's hard to show significance. Just quickly, the different study sites, mostly were clustered east and in the Midwest, with one in New Mexico and one in California as the sort of Western outliers. The timeline, as mentioned, 200 subjects enrolled and randomized. Everyone had a baseline PRO as well as an X-ray and blood draws. Then we had a 1 week, 6 weeks, 3 months, 6 months, and a final follow-up at 12 months. We also had a subset of sites that drew extra blood for biomarkers in addition to a CBC, a BMP, CRP, immunoglobulin levels, and an anti-HLA response. So this was a clinical trial that was conducted under good clinical practice guidelines, and it was designed to be acceptable to the FDA for potential approval, given that, as you might have heard, the FDA 2 years ago changed the guidelines for all of these allografts and regenerative medicine products that previously were able to go onto the market without having to show any trial data in terms of efficacy and safety. And now towards the end of this year, beginning of next year, the FDA will require data before they allow any of these products to go onto or remain on the market, just like they do for other medicinal products. What was interesting is that we had a rescue time point at 3 months, and if patients at 3 months answered that they had unacceptable pain and the treatment to which they were blinded had not provided adequate pain relief, then they were offered a rescue injection with ReNu. Since we didn't want to look at repeat dosing, the rescue injection was only offered to those patients who did not have the amniotic injection at baseline, so only the HA or the saline groups. If a patient from the ASA group reported unacceptable pain, they were considered a treatment failure and they left the trial. If the other two groups had a repeat injection that essentially reset the clock, and they restarted at their baseline and then concluded another 12-month follow-up, similar to what the original plan had been. Again, a lot of data. I won't read all of this, but this is just the demographical baseline data. There were essentially no statistical differences between the three groups in terms of age, sex, height, weight, and BMI. You can see these are the baseline reported outcome scores for the VAS, for the KOOS pain, and activities of daily living, all substantially the same. This tracks the results over 6 months. As mentioned, we just concluded writing up the paper for the 12 months data, and therefore I don't want to speak too much to these outcomes. But as you can see, the ASA injection in red really separates out from HA in orange and saline in blue. Somewhat surprising, HA did not separate from saline, but this is something that has been reported in other trials as well. And going back to looking at this specific HA, it actually was approved by the FDA on the basis of a non-inferiority trial. So it only had to prove that it's not worse than a control injection, which at least I learned a lot looking at this, and it did change my clinical practice in terms of HA injections. But again, so at face value, it's somewhat surprising, but doing the research, you will see that HA is unfortunately not that much better than saline, which explains some of the controversy that we've heard over the last 2 or 3 years for HA, which in many states is not covered anymore by some of the insurance companies for this specific reason. If you look at the KOOS symptoms, sports and recreation and quality of life all tell the same story. I wish I could tell you that any kind of injection is remarkably better than saline injection, but it's true for anything that anyone has looked at in terms of injections for knee osteoarthritis. Saline actually has a surprisingly good response rate, and you can be happy if you beat that at least. But what was more important really is if you look at the VAS results, and as a patient, I think the pain score is probably among the most important things. Here it separates out much more, where you can see a substantial drop from the baseline for ASA, and then HA initially dropped, but then as we've seen in countless clinical studies, towards the 3 and 6 months mark, it tends to migrate back to the baseline. And we see that specifically for pain during strenuous work as well. What's nice is the ASA injection actually kept improving even out to the 6 months mark. Certainly a more long-lasting effect than I've ever seen with steroid injections, for example. So more importantly than any statistics, because unfortunately you can provide statistical significance if you just have a large enough trial, but that statistical significance might not be clinically relevant. So here's the definition of MID, minimally important difference. That's pretty much how much better do patients have to be on their PROs before the patient would say, you know what, I really feel better. And that's what really matters more than minute little differences in the PRO scales. So the MID for the KOOS has been set somewhere between 8 and 10 points. Depends a little bit on what the pathology is that you're investigating. But the pain average was improved by 14.3, and the KOOS ADLs by 13.8, both well above the MID. And for the VAS, which is generally accepted to be somewhere between 8 and 13, we also see a substantial increase of 31 on a 150 millimeter scale. So importantly, not only statistically significant, but also clinically significant and relevant to patients. This is an interesting result from our rescue arm at 3 months. So if you look at the top row, these were withdrawals before the 3 months visit. These were dropouts for reasons unrelated to pain generally, and that's statistically not different between the 3 groups. These are patients who said, you know, I don't want to come in anymore, or they just lost to follow-up. But if you look at the second row, that's at 3 months, reported unacceptable pain, and were therefore eligible either for dropout if they had a previous ASA injection, or rescue injection if they previously had HA or saline. And we had worried right after we started the trial that we might have shot ourselves in the foot by allowing patients a rescue at 3 months. Because, and we probably overthought this, but we thought patients are clearly not stupid. They are coming and entering a trial which is inconvenient for them, rather than just doing whatever's offered to them following clinical practice guidelines. They enter into a trial because they want to have the cool thing that we are studying in the trial. They enrolled not to get a saline injection or an HA injection. They enrolled to get an ASA injection, and they could easily figure out that they had a 2 out of 3 chance of not getting what they actually wanted, because they knew that they would be randomized into one of 3 arms. So we worried that patients would game the system, that they would say that they have unacceptable pain relief, even if they didn't, just to make sure that they get an ASA injection. And if they had done so, you would have expected about equal dropouts in all 3 groups, given that patients were blinded. They did not know what injection they had. But as you can see here, the results showed that we were needlessly worried, because in the ASA group, only 13.2% of patients answered at 3 months that they had inadequate pain relief. While if you look at the HA group and saline group, here around 70% of patients answered that it wasn't good enough and they needed something else. So clearly, this was not due to gaming the system. This was a true response, a true experience. And I think that's probably one of the most important takeaway points from this trial, is the failure rate at 3 months. We also looked at, just because we wanted to investigate it a little bit more, what led to patients saying, hey, this is not good enough. So if you look at the sub-analyses and you separate the PRO changes from baseline in those subjects that reported or did not report unacceptable pain, it just confirms their more binary choice of yes or no based on their PROs. So those patients reporting acceptable pain relief, so the positive ones, demonstrated pretty high reductions in pain at 17 points, symptoms essentially 10, ADL, sports and recreation, quality of life, and most importantly, a decrease of almost 39 points in their overall VAS. If you compare to that, the second row, those that did report unacceptable pain, they didn't really change much from baseline. Overall pain went down by 0.83, so essentially nothing. And there were significant differences between all of these at the 3 months mark. So not only did patients binary say, hey, this was good or this wasn't good enough, their PROs also reflected that choice. When I discuss treatment options with patients, patients generally ask me, is this safe? So that's something our preclinical and the pilot trial had answered. What is my chance that this will work for me? And I'm getting to that on this slide. And then if it works for me, how much better do I get? And that's what I have just shown you. If you're trying to answer the how likely am I that this will work for me, you can either go based on the 3 months rescue data. So yeah, more than 80% with ASA, you will have acceptable pain relief at 3 months. You can also look at this from the viewpoint of our rheumatology colleagues who have the OMERACT and OARSI responder criterion. There are 2 degrees of response. There's a high improvement, where the subject must have a more than 50% decrease in pain or increase in function, as well as an absolute change greater than 20 points. Where there's an improvement if they don't quite get to the high improvement mark. And here they have to have two of the following. They either improve pain more than 20% and more than 10 points, or do the global assessment more than 20% and absolute change more than 10 points. So 2 out of those 3. For this specific trial, we used the pain VAS, the KOOS activities of daily living, and the KOOS quality of life. So if you look at the responder rate at 6 months, so we already know more than 80% responded at 3 months. This is a much stricter criteria than patients just say this helped or didn't help, because this is more based on PROs. Here we had a 69% responder rate with ASA, and both HA and saline hovered around 40. Going back to, well, how much better will it get if it works? At 3 months, the improvement in pain was about 70%, in function about 50 to 60%, and the global KOOS quality of life improved around 40%, both at 3 and 6 months. But how does this compare to other things? So ReNu, for example, in our trial, we had 69%, and for saline, we had 42%. There was a study investigating high molecular weight AHA, which demonstrated about a 59% response rate and 51% saline. There was another one for cross-linked HA that showed a 61% HA and 54% saline at 26 and at 13 weeks. So again, it is fascinating how well people respond to saline. Initially, everyone thought this is pure placebo effect. I give you an injection, it hurts, it's a big deal, so this better help. It's mind over body, but there are some thoughts now that saline actually might do something in a joint. So it might not be only placebo, there might be a true physiological effect, but that's being investigated. But reassuringly, we were better than saline. So in summary, these were 200 patients enrolled at 12 different sites. They were blinded to the allocation to either saline, HA, or ASA. There were no statistically significant differences at baseline in the demographics. We looked at the VAS overall pain, the KOOS pain, and the KOOS ADL. The ASA group showed significant improvements that were not only statistical, but also clinically relevant. Over HA at 3 months and both HA and saline at 6 months. Following the stricter OARSI criterion, 69% of ASA patients were considered responders, with 63% improvement in pain, 62% improvement in function, and a 37% improvement in quality of life at 6 months. But since we have some more time, I'd also like to use this opportunity to discuss a few of the questions that I frequently get in terms of what I do in clinical practice. Because trial data can be confusing. What's important is more, how do we incorporate this into a clinical practice? How do we change how we treat patients? So one question I commonly get is, when do you think injection therapy is not appropriate anymore based on structural changes? Would I inject someone who is Kelgan-Lorentz grade 4, so completely bone on bone? Or would I only inject patients who have still substantial joint space remaining? And I think for this, to answer this question, it really helps to look at the different buckets of therapies that we have available. So for me, there's one bucket, and that's steroid injection. Steroid injections have been around forever. That doesn't make them useless. They might not be very sexy anymore, but there certainly is clinical relevance and utility to steroid injection. And at least in the past, then we had another bucket that was pretty empty. There was only one thing in it, and that one thing were HA injections, and they were not as powerful as steroids. They didn't work for everyone, but they had the potential for lasting longer than steroids. And now we have a third bucket, and that third bucket consists of this regenerative medicine. And in that bucket, we find our PRP injections, our BMAC injections, fat injections, as well as placental products, amniotic injections. So when I see patients, my first question is always, is this mainly a structural problem, or is this mainly an inflammatory problem? And then how much inflammation is there? And we answer that one through the history in terms of how is your pain now compared to your pain a week, a month, 6 months ago. And if somebody tells me that they have a lot more pain today than they had a week ago because maybe there was an event, maybe they overdid it, that puts them into the activated arthritis category. Oftentimes on physical examination, these are patients who present with significant swelling, sometimes tenderness to palpation, they have effusions, they might have more limited range of motion due to the effusion than what they usually have. So this is a flare-up. This is definitely something that is elevated above their baseline. For that, we still go back to steroid injection, which I think is the strongest weapon, so to speak, we have. I aspirate these patients, I give them a steroid injection, I shut them down for a few weeks until their swelling has resolved. I oftentimes, if they can tolerate it, add anti-inflammatories orally, and I ask them to ice. They shouldn't move their joint, but they should not perform any impact activities. They should decrease their walking distance. They should go on a bike if they have access, just to keep the joint moving, but nothing strenuous until we shut down their flare-up. Some of these patients come back a year later and they say that steroid injection you gave me was fantastic. It lasted for a year. And of course, steroid doesn't last for a year, but it controlled their flare-up and they didn't have another flare-up for a year. So that's changing someone who has an inflammatory flare into someone who has quote unquote dry arthritis. The x-ray still looks the same. They might still be bone on bone, but since they don't have all the biologic activity, the inflammation in the joint, they don't hurt as much and they might be quite functional. This is very different from a patient who says more or less my pain is the same as it was a month ago, the same as it was 3 months ago. It might be a little bit more than it was 6 months ago or a year ago. So over time, their baseline has slowly worsened. And now they're just at a level where they have decided to come in and seek help. This, I think, is nothing that we can influence with steroid injections because they are too short lasting. So sure, if this patient says, it's really uncomfortable, I can do my activities of daily living, but hey, I want to go to this ski trip of a lifetime and I don't think I can do it, and I don't think that oral anti-inflammatories are enough, that's something where we consider cortisone injection just for short-term pain relief to allow them to do something that's really important to them. But it's not anything I would expect relief much past 2, maybe 4 weeks, and then I would expect them to go back to their baseline. So this is really where in the past I've used HA injections, physical therapy, oral anti-inflammatories, yes, but it's not something that I feel very comfortable putting patients on for months and months and months, given that there's a substantial risk of GI intolerance, elevation of blood pressure, and long-term effects on kidneys and heart. So this was where we've always been a little bit frustrated. This patient population is frequently younger, they're more active, they're in the sort of prime of their life. These are patients in their 40s who have mild to moderate joint space narrowing, which maybe with less activity, if they were older, they wouldn't notice so much, but they have young kids, they have maybe strenuous physical jobs, they need to do something, and we don't have great answers because cortisone, as mentioned, doesn't really work for them outside intermittent flare-ups. The HA, well, sort of works. I still utilize that in my practice because many insurance companies still do cover it, so it's better than nothing. But I have to say the outcomes haven't been all that great. So everyone desperately looked for, well, what else can we do? And that's why this field of regenerative medicine and orthobiologics has taken off as it has. People were desperate for other solutions. And these are the patients where now I consider injections with PRP or amniotic fluid. I get asked if I do use BMAC, if I do use fat, if I see any role in clinical practice for these injections. And I mean, there certainly is data to support the use, and I have used both BMAC and fat. The reason why I have migrated away from it is because I need to do an invasive procedure to get my graft. So yes, there's a certain attraction of using autologous tissue, and I think that's certainly valid and needs to be discussed with the patient. However, both in terms of patient discomfort and a small, but I would say relevant risk of complications, more so with fat than with BMAC injections. But aspirations from the iliac crest, while not awful, are not the most comfortable thing in the world. And a lipo aspiration from the abdomen, certainly also not the most comfortable. And then from a provider side, I certainly enjoy giving an injection where I just have a product that I inject without having to spend, I would say, half an hour is optimistic in obtaining a graft. I'm tying up an exam room, or better, a procedure room. I've never felt quite comfortable doing either of these in a regular clinic exam room. And the costs are relevant, given that it's a significant strain on other resources, whether you use a centrifuge or you need an assistant, you need a sterile field. So both on the patient and the provider side, I think there's a little bit of a negative to using BMAC or lipo. Hence my migration to other injections. What are the limits? Is this something where I would inject someone who has no joint space at all? Cortisone, yes, absolutely. I have no reservations injecting cortisone in someone who has a flare-up, even if they have no joint space remaining. HA, if it's an older patient who is at an appropriate age for arthroplasty, I don't try quite as hard doing HA injections because in my experience, they fail more often than they work in this particular subgroup of bone-on-bone arthritis. But I've had more success. This is gut feeling, anecdotal evidence. There's no trial comparing it in this particular patient population. But I feel that I've had a little bit more success in getting a response utilizing PRP or amniotic fluid versus HA, which I used to use for the past 15 years. But certainly patients who have more preserved joint space tend to respond better to any of these injections for sure. How do I decide between HA, PRP, and amniotic injections? Well, part of that is the reality of finances. HA injection many insurances cover. The ones that don't cover, there are some companies that have plans where they substantially reduce the cost for patients who don't have insurance benefits. And you can get these for a cost of around $500, maybe a little bit less, maybe a little bit more, depending on where you are and if you order in bulk. While PRP and amniotic is significantly more expensive. How expensive? It really depends on where you live. In New York City, PRP injections can be anywhere between $1,000 and $3,000. I've seen BMAC from $5,000 to $15,000. Amniotic tends to be somewhere between $3,000 and $6,000, and lipo injections are a little bit more than that. So I have a discussion with patients and say, look, if money doesn't matter at all to you, if all of these things are just a rounding error, which is very desirable and a little jealous, then I would do amniotic because I have good evidence that this helps. And if money is a concern, which is probably true for the vast majority of all of our patients, then I would start with HA, see if this helps. And if it does, that's good. If it doesn't help, then I would migrate up to either PRP or amniotic. Another common question is, how do I treat patients after injections? So I generally tell patients not to do any strenuous exercise. They can go on an exercise bike, but this is not riding the Tour de France. This is truly just for getting their joints moving. There's not much resistance. It's certainly not anything where I would want them to sweat or get their heart rate up. I don't limit activities of daily living. Stairs are fine. Walking is fine. I ask them not to try and intentionally put steps on their phone. Certainly not anything where they should complete their 10,000 or 15,000 step marker for the day. But they can move around. I don't put patients on crutches. I don't ask them to significantly curtail their activities of daily living, as I've heard from some other colleagues in New York. I do ask them to not use anti-inflammatories for the first week. There are some preclinical research studies that have shown that taking anti-inflammatories can decrease some of the beneficial effects of these injections. If somebody has a headache or cramps, it is perfectly fine to take an Advil or an Aleve. I just don't want them to go on heavy-duty anti-inflammatories 2 or 3 times a day, every day for a week. I think that, besides not being good overall, but it's certainly a potential issue for these injections. But they can use ice. They can, but don't have to use a compression sleeve. And they certainly can use Tylenol freely. One other very common question I get from colleagues that are interested in this product, but also from patients, is whether this is FDA approved. And I had mentioned this previously in the body of the talk, that until 2 years ago, the FDA really did not approve allogeneic tissue products. So the same way, if we use an allograft tendon for an ACL reconstruction, or we use allograft bone to treat bony defects, these are not FDA approved. They never went through clinical trials showing that they work. The FDA certainly has had requirements in terms of how do you harvest, how do you prepare, the packaging, the storing, but they didn't require the companies to do any specific efficacy testing as they do for medicinal products. But as mentioned, this is about to change. Within the next year, these FDA guidelines will now also apply to allogeneic tissue. And companies have known about this for the past 24 months. The FDA had set them timelines and has said if by the end of this year you are not able to provide data, or at least far along into a trial that will produce usable data to show us whether what you are making is safe and helpful, you will not be able to keep selling your product. And the FDA has already sent warning letters to several companies, not so much in the musculoskeletal realm. They have focused more on high-risk applications. There were terrible complications with injections of fat into eyes for retinal detachment or macular degeneration. There were intrathecal applications that resulted in complications. So the FDA has focused more on these high-risk applications, not so much injection into the joint, but you will see a lot changing within the next year. And currently, my answer, is this FDA approved or not, is what I just gave you. The FDA oversees and provides guidelines about manufacturing for these products to make sure they are safe. As of next year, certainly 22, we will be able to say, yes, this is FDA approved and no other products will be able to remain on the market. So overall, at this point, I would like to thank you. And you will now be redirected to the landing page to complete your post-test and evaluation. And then you will be able to download or print your certificate.